Hello, Dr. Bhatia, how are you?
Hi, Dr. Iqbal. Hi, everyone.
Hi, Akansha, how are you?
Good. How are you?
I like this timing also.
Yeah, weekend anytime works, right?
Yeah, yes. How was your international meeting?
Yeah, it was very good. Yeah.
Ah.
It was also like 2 hours. It was also like it gets a little exhausting after 2 hours of talking.
Yeah, I know. I can understand that.
Yeah.
Yes. So you must be really tired, but it's okay to have 1 hour, right?
Yeah. So we can just 1 hour should be fine. Like in the weekdays, 1 hour should be okay.
Yeah.
I think
You know-
Akash have mic, he says.
Yes.
Yeah.
From the internet, I could get this flow cytometry in the diagnosis of hematopoietic neoplasia by Brent Wood.
Yeah. That's the book.
However, I don't have that book which you are talking about.
No, I'm talking about this book. This is the one, Case-Based Approach.
I see.
This is the one that you got?
No, I got something on the internet.
Oh, okay. This is a book from CAP, and I have taken permission from CAP to read from this in Zoom with some audience from US and from international audience.
And this is also available for us to review on the internet.
So you should be able to view it in the flow course materials.
I see. Yeah,
So,
good.
Yeah.
As long as it is there, I'll just look into it.
Right. And today's session is more going to be a reading of a book like we used to do in the WHO book club. The plan being that we'll try to read the first 5 introduction chapters, these 5, and make sense of what they are trying to say.
Okay.
If you have questions, then just answer the questions meanwhile.
Okay.
Yeah.
Good plan.
Gonna start, guys?
Yeah, please.
Okay.
I think your core group is there already.
Yeah, we can start. Hi, Nidhi. Nidhi is here for summarizing. I like that. Are you connected to mic, Nidhi? Nidhi, hello.
Hello, can you hear me?
Yeah, I can.
Hi.
Hi. Kind of nostalgic, right?
Exactly. Feels so good.
Okay. So let's do our routine thing that we used to do for WHO book club. Introduction. Over the past 20 years, over the past 20 years, our knowledge of antigen expression in hematopoiesis and states of disease and health has grown tremendously. Immunophenotyping has become critical element in the diagnosis of hematologic malignancy, and flow cytometry is a well established. So all of this is all introduction. Widely used method for leukemias, lymphomas, and chronic myeloid stem cell neoplasms. So the publication aims and so forth, a brief introduction, and so basically is just introducing everything. And then, so over here he is showing, let me hide. Over here is showing the CD45 versus site scatter. So as I've been showing earlier, the CD45 versus site scatter, these are the granulocytes, these are the monocytes, these are the blasts, these are the lymphocytes. And so what he's showing is the CD45 versus site scatter in a normal marrow and peripheral blood as noted. CD45 is expressed with increasing intensity on most hematopoietic populations with maturation, and site scatter gives an estimation of cytoplasmic complexity or granularity. That's what I've been saying. By plotting CD45 versus site scatter, one can separate mature blue lymphocytes, monocytes in pink, granulocytes in green, maturing granulocyte forms, myeloid progenitors, that is in red, and lymphoid progenitors, that is in aqua. There's some problem. Okay. So note that myeloid progenitors and lymphoid progenitors are infrequent in the peripheral blood as compared to the marrow. So over here, they are showing the marrow in which there are these progenitors. In the peripheral blood, we don't have a lot of progenitors, obvious reasons. And then in the C, they are saying the CD45 versus site scatter defines blast gate contains cells other than blast. So that is important. CD45 versus site scatter. They have cells other than blast, including plasmacytoid dendritic cells, basophils. The PDCs and basophils colored aqua and purple respectively. So over here they are showing that the plasmacytoid dendritic cells and basophils that are present, and over here, if we want to differentiate between PDCs and these like purple colored basophils, then we have to go for HLA-DR. So the HLA-DR will be brighter in basophils and will be dimmer in PDCs. That's what I think. I hope I'm not reversed. All right. So therefore, specific cell identification is needed to complement CD45 versus site scatter gating. In considering cells with blast gate, CD34 can be used. Can someone, it's kind of disruptive. Can you guys see this black bar? Or you're not able to see it?
We are seeing it.
You see it, the black bar, right?
Yeah.
Yeah, it's kind of disruptive. Every time someone enters, I have to admit them, and that black bar comes. Anyways, so in considering cells with blast gate, CD34 should be used to specifically identify the progenitors, red, while CD123 to be identify basophils and PDC, on which this marker is expressed in high levels. Abnormal cells may stray from expected position on CD45 versus site scatter. The plot shows an example of hairy cell leukemia. So this is an hairy cell leukemia. Abnormal cells are shown in orange. These are the abnormal cells, in which have increased site scatter and overlap with CD45 versus site scatter defined monocyte gate. So these hairy cells will be more in the monocyte gate in case of 45 versus site scatter. So we don't need to read when to perform flow cytometry. We are well versed with that. Population identification. Specimens typically evaluated by flow cytometry for involvement of hematopoietic neoplasm include peripheral blood, bone marrow, variety of tissues ranging from lymph node, biopsies of non-hematopoietic organisms or organs. In most specimens, the neoplastic cells are present in the background that can range from normal maturing hematopoietic cells in the bone marrow or normal maturing T cell precursors in the thymus to what Akash is doing something. Akash has some trouble here. Yeah, so this is kind of disruptive. Maybe I don't know if I can stop. Let me try to not make myself co-host, and so that's Kanksha Gupta. Okay. So I think I would be, I think I would now not have this maybe. Let's see. Okay. So we were reading. In most specimens, The neoplastic cells are present in the background that can range from normal maturing hematopoietic cells in the bone marrow to normal maturing T-cell precursors in the thymus to reactive lymphoid cells in the lymph node. Being able to identify the abnormal population requires not only recognition of the immunophenotype of the abnormal population, but also knowledge of the normal antigen patterns. So that's what we have been doing till now. We have been reading the normal antigen patterns in detail so that we can know what the abnormal looks like. The reader is referred to the selection of excellent references that has, okay, we already read that. This chapter presents an approach to population identification with an emphasis on normal antigen expression with differentiation maturation of the major hematopoietic lineages. In addition to immunophenotypic changes seen with maturation, we review the changes that can be seen with cellular activation, which we present an antibody panel that has been used with success in our laboratory. Okay. CD45 versus site scatter is useful initial strategy for determining the cellular composition of the sample. CD45 is expressed with increasing intensity on most of the hematopoietic lineages with maturation. The site scatter gives estimation of the cytoplasmic complexity or granularity. By plotting 45 versus site scatter, one can separate mature lymphocytes, monocytes, granulocytes, maturing granulocyte forms, myeloid blasts, and lymphoid blasts. Mature lymphocytes, monocytes, granulocytes all have high levels of 45, but can be differentiated by site scatter, which is highest in granulocytes, intermediate in monocytes, and low in lymphocytes. Immature myeloid cells typically have lower CD45 expression, with site scatter similar to that of mature granulocytes. So immature myeloid cells have typically less CD45 and site scatter similar to mature granulocytes. Myeloid and lymphoid progenitors have decreased CD45, with myeloid progenitors having similar site scatter to monocytes and lymphoid progenitors having similar site scatter to mature lymphocytes. So let's see this progenitor development first. So all panels depict 45 versus site scatter, defined blast gate. The earliest progenitor cells express very high levels of 34 without 38. So that's an important point that they want to make is the earliest progenitor will be having high 34, bright 34, and will be negative for 38. And with maturation, 38 is acquired and 34 is lost. Maturation towards the myeloid lineage is accompanied by acquisition of 13. So these are all the signs that we already came through. And if you remember, there are some of the signs that we have already read. So for example, we read this sign that has 34 that goes from here to here, and then the 33 that increases and then goes back again down. So those things, sorry, the 34 that goes down. So we have read all of these signs, and that's what they are showing here. The solid arrow characterizes changes in antigen expression seen in blast towards the lower of myeloid stage. Okay. So that's the progenitor development, and we already saw this myeloid development as well. I think we went through this yesterday. So this they are not only showing the normal here, they're also showing the abnormal here. So that's why I wanted to go through the Brent Wood book. So they have shown over here the normal, and let's see what they are writing about it. So we already know about 13 versus 16. So 13 versus 16, when the granulocytes mature, they kind of first there is in 13 there is a dip at the myelocyte stage, and then they acquire 13 again, and then 16 is gradually acquired. And then as blast transition to myeloid stage, they acquire high levels of 13 and 15 and 33. And the upper panel depicts normal myeloid maturation with myeloid elements shown in green. Monocytic elements are included in B in pink for comparison. Promyelocytes have high expression of 13 and 33 and 38. So over here, if you would see, this over here is the promyelocyte expression, promyelocytes. So basically, there is high of 38, there is high of 13 over here as well. Over here, this is the promyelocyte. There is high in 13, and high level of 13, 33, and 38. And the levels of 33 and 64 on promyelocyte is below that of the mature monocyte. So that's what they are showing over here, that the promyelocytes have low 64 as compared to the mature promonocytes. And the levels of 1364 on promyelocytes are below the, okay. With maturation, myeloid elements lose 13. So that's what I was saying, that with maturation, they lose 13 and then again acquire 13 and 16 together with high level expression of both antigens on mature neutrophils. The pattern of 13 versus 16 may be altered. So now they are showing the altered patterns. First over here, they are showing marrow regeneration under the influence of GCSF. So that's what they are showing, that in the marrow regeneration, the pattern over here is kind of altered with the 13, as you see, is not like these cells are not present. Then left shift, and then there will be, because of GCSF, there will be more of the new forms or the later forms that are developing, and it's more maturing. So that's why the more immature forms are absent. Left shift myeloid maturation. So again, in the left shift, there will be more of immature forms. So and then there will be less of mature forms. So this is more of the left shift maturation. Then PNH. PNH is decreased CD16 expression. So they are showing this blob that has decreased CD16 expression in the subset of the mature myeloid cells. So we know that they are mature. There is 13 that is over there, but there is no 16 in these ones. So these 16, 15, and other markers, 59, 55. There are other markers that are used for PNH, but for the grant, 16 is one of them which is used. So I actually was.
Akanksha.
Yeah.
Question. So I was reading it somewhere. I mean, if you can clarify that when we have a diluted specimen, it becomes more of 16 rather than 13 and 16 on a bone.
See, think about it. If you really think about it, hemodilution means what? Hemodilution means that it is diluted with blood, right? So if it is diluted with blood, what will it have? It will not have more of the immature precursors. It will have more of the mature forms, right? So if you go back to this picture, so there will be more of these mature precursors, mature forms that will be present in a hemodiluted marrow. So that's something that you have to remember, that the immature forms will not be there, and in a hemodiluted marrow, you'll not see this kind of graph. You'll rather see more of the mature forms.
Oh, okay. Thank you.
Yeah. Yeah, so I was reading a little bit over here. So let me read the highlighted part so that I don't waste all your time. So let's see. Several factors complicate CD45 versus site scatter differential. For instance, in addition to progenitor cells, several populations, including basophils and plasmacytogenetic cells, fall within CD45 versus site scatter defined blast gate. That's a very important point. So these are the cells that fall into that blast gate. And additionally, in states of disease, the expected CD45 versus site scatter of certain population may be shift. For instance, large B-cell lymphoma or hairy cell leukemias, the abnormal B cells often have high site scatter, leading to overlap with monocyte population on CD45 versus site scatter gating. And in myelodysplastic syndromes, granulocytes may show increased cytoplasmic granulation decreased cytoplasmic granulation. So this is important, like the site scatter will be reduced in case of hypogranular neutrophils or hypogranular the precursors, even if they are present. So those will have low site scatter, leading to overlap with the monocyte gate again and a blast gate on CD45 versus site scatter gating. For these reasons, CD45 versus site scatter is used to guide initial specimen analysis. Refinement of these initial gates with the data from additional lineage associated antigens is critical for optimal population identification. Right.
I have a question.
Yeah.
So they were saying that in large cell lymphomas and in hairy cell leukemias, hairy cell lymphomas, they will fall in monocyte gate. Then the cells will have an increased site scatter. I was just trying to figure out why. Like they don't have an increased granularity or anything, right? In those cases, so why would they have increased site scatter?
See, the site. Yeah, please. Someone was saying something.
Yeah, the site scatter is not just about granularity, it is also about the complexity. Plus, when you have large B-cell lymphomas, you will also have the cytoplasm, I mean, the nuclear chromatin would be a little bit opened up. You might see some nucleoli and stuff. So it tends to have a larger size, and also it tends to have a little bit different or heterogeneous complexity in its in the size. I mean, in the nucleus, which is why the site scatter would be high. And the same with hairy cell leukemias. Also, you will see that is more due to the cytoplasm, irregular cytoplasm that scatters the light irregularly, because the projections will interfere with the site scatter, which is why they fall in the monocyte gate.
Okay, got it. Thank you.
Okay, so this is the same thing. So again, here I was showing that this is the promyelocyte, and here is the left shift, there is the regeneration, there is low 16 BNH. Several changes can be seen with neutrophilic activation or marrow regeneration that can alter expected antigenic pattern. For instance, neutrophils may upregulate 64 or downregulate 16 under conditions including traumatic injury and exercise, and marrow regeneration can lead to acquisition of low level of 56 on the maturing myeloid forms. So these are the things that we can remember. In regeneration, you can have low level of 56 in the maturing myeloid forms.
I have seen this 56 like acquiring like the mature myeloid forms acquiring 56, and there is the marrow is normal very often in my practice. Like I have seen like 3-4 cases so far, and first time I'm getting like, why is it so? Thank you.
Yeah. And then subset of circulating activated monocytes are known to express CD16 with slightly decreased levels of CD14, 33, 64, and HLA-DR. Also, similar to myeloid cells, monocyte cells may acquire low levels of 56 with activation. All right. So that can be like the phenotypic variations in the monocytes that they are discussing over here. Yeah, this is an important point. With differentiation to erythroid lineage, the early CD34 progenitor acquires CD38 and high levels of CD117. So we know that 117 is a precursor or early blast as well as myeloid, immature myeloid marker. But one thing you have to always remember is the early progenitor erythroid cells, they will also have high levels of CD117. This progenitor then drops CD13 and 33. So now they are becoming more lineage specific, and then loses 38 again, and then loses 117. And the CD45 declines, while now the CD71 is acquired. So now what is going on? The 34, 38 is there, 117 is bright, and then it is dropping 13, 33, it is dropping 38, it is dropping 117 and 45. And all of these are dropped, and then 71 is acquired at the high level. Following this, there will be glycophorin and heme that will be acquired. With the loss of nucleus, as the erythroid cells enter into the late retic stage, the CD71 will be lost. So this is something that is an important point to remember. So the myelomonocytic maturation and everything we have already seen. They are showing some other deviations, I think, over here. So let's see. Monocytic cells are shown in pink and myeloid cells are included, shown in green for comparison. Maturing monocyte cells have high levels of 33 and 64 expression at all stages of maturation. So 64 is brighter in case of, we have been reading that all the time. 14 is acquired at high level with the maturation. Black arrow depicts the antigen expression seen on the monocytic cells with the maturation. This one. The pink arrow highlights the subpopulation of CD16 monocytes, which may be seen with increased in some inflammatory states. So over here, CD16 positive monocytes that can be increased in the inflammatory states. These may have lower levels of monocyte markers, but should not be mistaken for immature monocyte cells. So that's their caveat, that these cells should not be thought of as immature monocytes. They can be seen in inflammation. All right. Basophils, PDCs, and eosinophils. Eosinophils shown in orange. So basically, they are the CD45 versus site scatter. There are these eosinophils, and after this, they are removing the grants. So you can see this gate also has grants over here. They're removing the grants by doing 16 versus 45. So 16 are removing the grants, and then you have the pure eosinophilic population. So eosinophils shown in orange are identified by creating rough gate circle around the myeloid cells with high CD45 and site scatter, selecting the mature myeloid forms lacking the CD16. Basophils and plasmacytogenetic cells fall in the blast gate. So over here, the basophils and PDCs will fall in the blast gate as defined by 45 and site scatter. Both populations are differentiated from blast and other cells with the blast gate on the basis of high expression of CD123. However, as I was mentioning, that the HLA-DR is going to differentiate between those. So the expression of basophils purple and the PDC aqua. So the PDCs will have the higher HLA-DR and the basophils have the lower HLA-DR. So that's how they are going to be differentiated. Then coming to early B cell development. These are the hematogones. So this hematogone pattern is important to know. Right. So the hematogone pattern is also important, and we should know how normal hematogones are. When you have the normal, like the different kind of, so this CD10 versus CD20 plot, this kind of pattern is very typical of hematogones. So basically, the hematogones, if you see the B cell, so if you see the B cell development, the early forms, they have CD10, and the late forms, they start having CD20. So there is like kind of a spectrum in which CD10 is there, and then it loses CD10 and it gains CD20. So that's what they are showing over here, that first they have CD10, and then they start losing CD10. And then when they are coming to the mature stage, they have lost CD10 and they have gained CD20. So let's see what they are writing. The stages of stage 1 of hematogone. So stage 1, they are showing in aqua. They have different stages that they have labeled for the hematogones. And they express CD19, CD34, bright CD10. So this aqua is expressing bright CD19. And so they're expressing CD19 wherever. So this, they have gated somewhere in CD19, which I cannot see. So they have actually, these are all actually CD19 positive cells. So basically they will have the CD19, and they will have CD34. So obviously they are the early precursors, so they will have the CD34 in them, and then a bright CD10. A decrease in CD10 expression with the loss of TDT and gradual loss of 34 marks transition to stage 2. So it's the same thing that I was showing over here, that the loss of TDT, loss of 34, and the increase of CD20, that will mark the loss of TDT, loss of decrease in CD10, and gradual loss of 34. That is marking the stage 2, that is showing in yellow. The most abundant hematogone population. So this yellow is the most abundant hematogone population in most of the bone marrow specimens. CD20 is acquired with increasing intensity during the stage 2. So eventually in the stage 2, it is acquired in increasing intensity, as is the surface immunoglobulin. And the expression of, so basically when it is in the mature stage, we know that there is no surface immunoglobulin that is present. And when it is acquiring, now it is starting to acquire the surface immunoglobulin. Expression of CD20 is expression of CD20 at a higher, at a level slightly higher than mature B cell signals. Transition to stage 3 now, shown in blue and red. So this over here, blue and red, is stage 3. Reflecting, basically this blue and red now over here, they are showing that the stage 3 will now have expression of kappa and lambda respectively. So now they will be polyclonal over here. With the loss of CD10, the maturing B cell stage is reached. So when there is loss of CD10, they are the mature stage already. Changes in the antigen expression with B cell development are depicted in the arrows. So again, the CD20 acquisition, as you can see, and then again CD20 acquisition, and the CD38 will be eventually lost, and then again, so 38 is lost in the mature stages. So again, over here, there is bright 38, and then it kind of loses 38 over here. Similarly, CD10, it is kind of lost. So this is the pattern of hematogones that we have to always remember. I think we also had, in our book, Brian made very nice figure of hematogones, but let's see. Just a second, I got a message.
I think we also had a table of the transition, Akanksha.
Yeah, no, Brian had made very nice. I want to go there. Let me, my drive is my path. And to copy to distribute. Stick.
Okay, I think in the meantime, I'll answer Halima's question.
Oh.
She asked in the chat box, eosinophils have high degree of autofluorescence. And she asked to explain what that means. So some granules, for example, granules of eosinophils and granules of promyelocytic leukemia, they have autofluorescence, which means even without adding the fluorochrome, they can have they can emit some amount of fluorescence that can be captured by the detector. So some laboratories, they actually set up one tube for suspected APL cases, or even in their routine myeloid cases, to detect autofluorescence. That's what it means. Basically, it's the property of the granules of the EOs and APLs. So what they are saying when they say, let me read your question again, apparent positivity for low emission wavelength fluorochromes, which means the cells should not ideally be positive for a certain marker, but let's say, for example, eosinophils should not be positive for CD19. But if they show a slight positivity, it's not because of the antigen or antibody itself, it is because of their granules, which have autofluorescence. That's what it means. But
Right.
19 is just like a wild example. I'm just saying the concept is that it sometimes has some positivity where it should not be because of its autofluorescence.
Yeah, that's a very important concept to remember. So this is the same thing that we have shown in our book as well. So the same thing. So basically, just in a little bit more elaboration. So basically, there are these 4 stages, and he has nicely shown the 4 stages as pre-B1, pre-B2, immature transitional B, and the mature B cells. The pre-B cells, they will have TDT 34, 38, CD10, and DIM of 20 to 45. The pre-B2 H2 will have DIM of 10, will have DIM of 20 and 45, and then the 20 will rise in the immature H3, and they will have 20, and the mature B cells will have the 22 and the 20 and DIM 38. So let's see over here what's going on. So this is how the maturation is going on, and there is 34 that is brighter in the early forms, which is lost as we go with the acquisition of CD45. And then the TDT is eventually lost, and the CD10 is eventually lost. So that's that. And the CD22, it gets acquired in the more mature forms, and there is kind of a dip in the immature, in the stage 2 stages and immature forms. CD38 is in the early precursors, so we know about that already, and then it kind of dips down. As so, the CD20 kind of acquires in case of the stage 2. And again, this graph is very important, the most important, CD10 versus CD20, which we use in our clinical practice for looking into it. And again, CD38 being lost and CD10 being lost, 22 being acquired. So that's in the later on stages, the 22 becomes brighter. So that's like a nice depiction of what goes on with the hematogones. I think yesterday or something, Shweta had a question, or someone had question about what happens in hematogones. I think someone had the questions in the YouTube. I'm blinding on who had that question. Okay, so that's the hematogones. I hope that is.
Akanksha, I know it would definitely come up later in the sessions, but I think hematogones could be confused with the BALL cells.
That's why they are important.
Yeah.
That's why
Is
the
there
reason
any
that they're
particular
important.
marker that helps, like, or is the pattern that helps the most?
Yeah, to me, the pattern helps most. Like the hematogones, they will have that kind of variable expression, 10, 20, and so forth. But, and also they look different in case of morphology. But at the same time, the BLL will be a big blob that will be sitting, and it will not be having that particular maturation pattern. Rajeshri, you want to?
Yeah, basically it's the dynamicity of the population, whereas in hematogones you will see all different phases at the same time. You will see that the maturation is happening and they will all be a continuous population, whereas in pre-BALL the dynamicity will be off and they will be at one stage.
Right.
Basically it should be it loses the heterogeneity. That's what matters the most. And actually, if you see CD45 versus side scatter for hematogones, we will show it when we do our BALL sessions in the later. You will see that it starts from below. I mean, you will see them below the blast gate actually, and they will start from this end and they will go all the way to the lymphocytes and merge with them, like a small spectrum from low end of CD45 to all the way to brighter CD45. It's a very continuous, distinct population actually sometimes. We'll show you that, but that's what it is basically. You will see that it's starting from the blast and going into the lymphocytes, whereas BALL will be homogeneous and stuck at one place.
Okay, thanks.
All right. So let's go ahead and read what they were saying about here. Yeah, so we
also,
already...
like you said, sorry. Also, like you said, there are some aberrant markers too, like CD58. We will, and CD1333, we will also discuss more into that when we do BALL, but just because you asked about markers, we do have some markers that can help.
Right. All right, the PDCs express high levels of HLA-DR. Basophils will expressing low levels of HLA-DR. And basophils also express a high level of CD38. So these are the important points we have to remember. Last major subpopulation is not to have eosinophils. These have high CD45, high site scatter. We already read about that. Differentiated from based on 16. So we already saw all of that. And studies suggest that earliest marker expressed on B cell progenitors include CD34, 79A, TDT, and CD10. With acquisition of 19, these early B cell precursors are considered as hematogones. Hematogones can be identified in the most marrow specimens, shown an inverse relationship to the age. For example, with infant marrow showing the highest percentage of hematogones and may be increased in variety of conditions, including the patients with lymphoma, regenerative marrow states, immune-mediated cytopenias, and acquired immunodeficiency. Hematogones can be divided into 3 stages. So stage 1, early, that expresses 19 TDT, 34, bright CD10. Decrease in CD10 expression with loss of TDT and gradual loss of 34 marks to stage 2, intermediate, and that is the most abundant in the bone marrow of the hematogones. CD20 is acquired with the increasing intensity during the stage 2, and as is the surface immunoglobulin. And expression of CD20 at the level of mature B cell transitions to stage 3 with loss of CD10 and mature B cell stage is reached. So that's that. So let's see what they are saying over here. So this over here, they are saying that it is a reactive lymph node. And I showed in the morning session that the reactive lymph node, there are 2 markers. So actually, if we go into, not sure. Okay, if we go into here, so this is the follicular phase, right? So if in the follicular phase, you can see there is the follicular or germinal center markers that we know of, that is 10 LMO2 BCL6 at GL. Amongst this, we do 10 for the flow cytometry. But there is another hidden marker that you should know about is CD38. The CD38, it will be in early forms, as we saw already in the B cell progenitors. But it will also be in the follicular phase or in the germinal center. So this is another marker that is important, and this is why this is important, because when you have the CD10 versus CD38 in the plot, you'll see these prominent follicular like the germinal center or the follicular cells, which are because of the reactive lymph nodes. So that's something that you have to remember. And then they are also saying that the plasmacytogenetic cells, they will be having some CD38. Also, basophils have some CD38, so that's something to remember. And the B cells, like the CD20 positive B cells, they can have CD5, some CD5 expression. That's what they are saying in the later stages. Let's see what they are reading. As noted in the text, reactive mature B cells subset show characteristic pattern of antigen expression described. The oval contains germinal center B cells. So these are the germinal center B cells. The germinal center B cells will also have bright CD20. So that's something to remember. Bright CD10, bright CD20, bright CD38. This figure depicts, representing reactive follicular hyperplasia, which expresses bright 20, 10, intermediate 38, and CD10. The CD10 B cells are shown in yellow, and CD10 positive B cells are shown in yellow in the lower panels, are noted to demonstrate polyclonal light chain expression of note. So they have polyclonal light chain expression. And then you see that over here, the light chain expression of the CD10 positive B cell is down regulated, as you see over here, this population, as compared to that seen in the normal background B cells. So these are the normal background B cells that are polyclonal, but you can see over here there is down regulation of the kappa lambda, and shown in red and blue. Okay. A small subset of B cells can express CD5. That's the black arrow. And subset of plasmacytoid B cells. So these are the, not PDC, these are the plasmacytoid B cells. They will express bright 38. That's what I was thinking. So the basophils will be 38, but these are the plasmacytoid B cells, not the plasmacytoid dendritic cells. Okay. Let's see what they are saying here. Yeah, so about the LGL, so they went into T cell maturation and T cell everything. We read about T cell maturation yesterday, I think, and it's kind of though becoming blurred as to which session has which discussion already. But the large granular lymphocytes are cytotoxic T cells expressing CD3, CD8 with variably decreased CD5 and a normal expression of CD2 and CD7. The LGLs are usually positive for CD57, variably positive for 56. LGLs may be increased in a variety of reactive conditions, ranging from infections to inflammatory. However, if there is a persistent elevation of the LGLs, in the setting of cytopenias, particularly neutropenia, it should be giving rise to concern for LGL leukemia. So that's an important point. And we read that in our WHO book club, if anyone remembers that too. So they are showing over here the T cell development, and the T cell development, if I'll show you, the CD3 is acquired as the T cell matures, and so the acquisition of CD3, that's important. Again, similarly, over here, they are showing it is going from here to here. This is being the most mature T cells. So there is, and this is more in the thymus, because in the thymus, you will start having all the stages of T cells on maturation. Let me show you. Actually. So this over here, the thymus, right? So the thymus will have all those stages of the T cells, and the thymus will have all these that they are depicting over here. So what they are saying is that there is an acquisition of CD3. So let's see. So over here, you can see that initially in the initial stages, there is this cytoplasmic CD3, and then there is acquisition of surface CD3 that happens. And then they are showing that initially they are like double positive CD4, CD8 T cells. And then eventually when it matures, it becomes more specific to CD4 versus CD8. So that's something that is an important finding. Okay. Then there is gamma delta. Gamma delta T cells are typically present in low numbers, less than 5% of the T cells in the peripheral blood, but can increase in number in some reactive settings, infection, inflammatory, or post-splenectomy. The gamma delta T cells are found in greatest numbers in the splenic red pulp, intestinal epithelium, as well as other epithelial sites. This mature T cell subset expresses bright 3 without 4, with low or absent CD8. So low or absent CD8, I think they have shown in some picture, these gamma delta, maybe in the next picture. But bright CD3, let me see the next picture. Yeah, I thought that I saw this picture somewhere. Anyway, so expresses bright CD3 without CD4, low or absent CD8. Subset of memory T cells are CD4 T cells expressing 2, 3, 5 with variable loss of 7. These may be increased in blood or tissues in a variety of reactive settings. 2 additional CD4 positive T cells subset, which are of note, are follicular T helper cells, which expresses the germinal markers such as CD10 along with BCL6, CD57, PD1, and facilitate the germinal center reaction. And the T regulatory cells, which expresses 25 and FOXP3, are involved in the limiting the immune response. So this We already saw this over here, right? So the T regulatory cells, TFH that we were talking about, the TFH having CXCL13, PD1, ICOS, BCL6, and CD10, and the T regulatory that is having CD25, FOXP3. And I have been emphasizing again and again that these TFH cells are more of the TFH phenotype of T cell lymphomas, including the angioimmunoblastic and some of the peripheral T cell lymphomas as well. And the T regulatory, they give rise to ATLL, the adult T cell lymphoma leukemia. So then you start having CD25 in those cases. Okay. So then they showed their panels of standard panel of the hematopoietic neoplasm, and they were showing all the fluorochromes that they are using, and the tubes, the B cell tubes, T cell tube, myeloid tube, and I think it is a 10 color flow, 1, 2, 3, 4, 5, 7, 8, 9, 10. Yeah, it's a 10 color flow. And they are showing what in what tubes, what they are putting in there. So 20 kappa lambda, 5, 19, 38, 10, 45 in the B cell tube. 2, 3, 2, 2, 5, 4, 8, 34, 56, 3, 7, 30, 45. And then myeloid 1, they have 15, 33, 19, 7, 1 and 7, 13. So that, I mean, we don't need to go into detail of these, but that's how they have structured their lab. And that's how Woodlist is actually structured too, like the ones that we used to have. Okay, so that's the first chapter. Any questions so far? The next few chapters are very small. Like this chapter is, I think, just 2-3 pages. Any questions? Anything to add, Rajeshri? You want to add something?
No, I think we're good.
Okay, good.
Sorry. Hey, Kanksha, is there any like which fluorochrome should be attached to which marker or like antibody? Is there any specificity to it, or it's just a panel that a standard panel that everyone acquires? Like P should be linked only, like for example, P should be linked to CD5, or can P be linked to CD34 also? Like, is there something like we can play around with these fluorochromes with the markers, or it's a standard panel that everyone follows?
I don't think it is a standard panel. I think it can be played around, but Rajeshri, Rajeshwari will be having better idea than me because she went in the lab and especially saw all of those things.
So the thing is, like, some of these fluorochromes are more brighter and some are dimmer naturally, and also the nanometer in which their natural fluorescence occurs, changes their behavior. So when we do that, we see that the antigen that is most expressed on a cell will have a dimmer fluorochrome, and when the antigen that is least expressed on the cell will have a brighter brighter fluorochrome. So that and also the antigen of interest in any study, like aberrant expression, that will also be tagged with a brighter fluorochrome. So that, if in case, for example, if you tag an antigen that is commonly expressed, let's say CD45, and you tag that with a brighter chromosome, that means that it will double up its brightness and it will spill over into the other channels, and that will be detected by other fluorochromes as well. I mean, other detectors as well. So we don't do that. We try to match it based on the expression level and the brightness. So brighter will be with the lesser number of antigens, and dimmer will be with the brighter more number of antigens. And also they if when you cannot, like, individually, when you're running your panel, you cannot change the fluorochrome, because when you design your panel and when you tell your manufacturer, they will tag the antibody with the fluorochrome, and then only they'll give it to you. So when you design your panel itself, you have to decide based on that. And also, if you're using, for example, a 10 color equipment, when you design your panel, you have to make sure all those, when you standardize itself, you should make sure that your fluorochrome combinations work very well without any compensation issues or any spill, and then you cannot change after that. And so that's why when you use your panel, they will not use two antibody of same fluorochrome in one tube usually. So for example, if your 13 or 33 is also PE and your lambda is PE, you won't see that in the same tube. So people have to use a separate tube to study that. Do you understand what I'm saying?
Yeah, but it's just like if I mean I get the abnormal one you use a brighter fluorochrome, but like the normal ones like 257 per se, how would I know like which marker is more on like to me like two in a mature T cell 257 they are equally expressed like
Right.
so any of the fluorochrome can be used like brighter or lighter for them, right?
Right. So for that, it doesn't really matter, but it's just that so these have to be tested in tandem also. So they are tested protocols. For example, almost everybody universally uses FITC with kappa and PE with lambda. That's because that's all validated very well and tested. So most labs will go with that combination, and also your manufacturer will give that combination.
Okay, got it. Thanks.
Okay, cool. Thank you, Rajeshwari.
No problem.
Okay. So now they are going into the B cell neoplasms, and here they are showing the B cell. This is actually a B cell lymphoma. Without looking into what it is, can someone tell? Let me decrease this. Can someone tell what kind of lymphoma they are depicting?
Follicular maybe it's kappa restricted.
Right. So that's what they are showing over here, and it is kappa restricted. There is CD10 that is expressed, and there is B cell markers CD19, 20, and forward scatter CD20 is there. So they are also showing that the CD20 expression is kind of little bit dimmer as in case of these cells as compared to the normal B cells. So these are the normal B cells that you have over here.
So when you see something that is co-expressing CD20 and 10 in a mature B cell lymphoma, you'll have to think twice before calling it as follicular lymphoma in just by flow, because it could be a diffuse large B cell lymphoma
DLBCL
also.
and others.
Especially with this amount of forward scatter, we may have to, it could be like anything that is from the germinal center, like bucket or DLBCL. So just when we see this, when the reporting line is usually B cell lymphoma of germinal center origin, that's where we stop.
We usually say CD10 positive, abnormal CD10 positive B cell population identified, and then mention all the aberrancies, and then we say that correlation with the bone marrow, and basically, or the lymph node, and basically it could be anything, as you said, Burkitt's, diffuse large B cell, follicular. But at the same time, the forward scatter sometimes helps you. So the forward scatter in the DLBCL will be definitely higher than also the side scatter will be definitely higher than the follicular lymphoma cells. So that's something that helps you. And when we have those kind of higher forward scatter cells, we mention that. I mean, many a times we do know the background morphology as well, but if it is very clear cut and if it is there, then we mention that these cells have high forward scatter. So that's that. Okay. So coming to normal B cell lymphoma, the antigen expression, and they are showing us the more mature B cell lymphomas, CLL, mantle, follicular. We are going to go in these cases, if possible today or tomorrow, whenever. But let's see what they have, and every one of us by now know this pretty well. But the revision doesn't hurt. So CLL, SLL, CD5 positive, CD23 positive, and CD43, 27 are not that like that useful or important. BCL2 will be there as well. Mantle cell lymphoma. So Mantle cell will be CD5 positive, and they haven't given the FMC7, but FMC7 will be positive. We'll come into details of all of these. I mean, cyclin D1 is positive. We'll come into details of these as to how bright the surface immunoglobulins is, how bright the FMC7 is, 200, and other things that we'll see in our cases as well. Follicular lymphoma, as we know, the BCL2, but at the same time, the CD10 will be positive, and the other cases, the CD10 is negative. So the CD10 with BCL2 is follicular. Hairy cell leukemia, you'll have the other markers, say 103, 123, 25, 11C. Okay. So we don't have, so then they are going to the T cell neoplasms, and this one they are showing is a PTCL, peripheral T cell lymphoma, and they are yeah, that's right. I saw this, Halima, the question that you had. The CD200 is a recent marker that is used for CLL, and it is pretty good for CLL. Yeah, so this is a normal T cell population that they are showing, and this population has downregulated CD3. So this is the abnormal population that has CD5 but has downregulated CD3, and also downregulated CD7. So this is the normal T cell population, and this one has downregulation of CD7. So, and then this population is more of CD4 rather than CD8. So, and this green and red, these are the normal T cells on the background. So basically, this population is the population of PTCL. So that's what they showed in here. And then they went into the T cell lymphoma. We'll go into that when we are doing the T cell lymphoma. That will be better. This I wanted to come to. So yeah, yesterday, I don't know if I was discussing with you guys, but I was saying that MDS, we have that nice chart that, like we read all the normalcies, we read all the normal expressions of myeloid, monocyte, and other B cell precursors and everything. But why do we need to read all of those normals? Because we need to identify the abnormals as in case of MDS. So they have given this nice data on MDS, and this was taken from the reference which I remember somewhere. But the myeloid progenitors, when there is a increase in blast, of course, so that's one of the things. Then expansion, can you see it? Should I increase it? Yeah. Expansion of immature stem cell compartment, CD34 positive and CD38 negative. More of immature stem cell compartment. Aberrant expression of non-lineage specific markers. So for example, T cell markers, if the myeloid progenitors express 5, 7, or B cell marker CD19, or NK cell marker CD56. And abnormal intensity of antigen expression. So intensity. So again, the 13, 33, 45, 34, 117 HRDR, the kind of intensity that is expected if there is an abnormal aberrancy in that intensity, then we have to think that they are abnormal blast, even if they are not increased in numbers. Like they can be really 2-3%, but in the bone marrow, which would make you think, okay, there is no increase in blast. But however, they have abnormal expression of the antigens that they should express. Homogeneous expression of antigens normally expressed at variable levels. So basically, if the antigens that we have been seeing, 13, 33, 117, all of these, 34, all of these, we have seen that the precursors or progenitors, they have variable expression on these. However, when you start seeing a homogeneous expression, that definitely is kind of abnormal. Asynchronous expression of antigens associated with maturity, with antigens denoting immaturity. So again, the bright CD34 with a bright CD15, that doesn't make sense in our minds. So this is an immature marker, this is a mature marker. What the hell? So basically, that's what it's the asynchronous expression. Then in the myeloids, more mature myeloids, decreased site scatter. So obviously, the decreased site scatter would mean that there is a hypogranularity. So that's another feature of MDS. Decreased CD10, abnormal 13 versus 16, abnormal 16 versus 11B, abnormal 16 versus 14. abnormal retention or of absence of CD64. So retention or absence of CD64. Left shift, increase or decrease by 1/3 of the log scale in the expression of myelomonocytic antigens. So again, this will only identify if we know what the normal looks like. And I mean, to me, truly speaking, this is really hard. I am not very good in, still not very good in identifying everything that are abnormal populations. Monocyte. So monocyte CD56 co-expression. So when CD56 is starting to co-express, increase or decrease by 1/3 or decade on the log scale in expression of myelomonocytic antigens. So 13, 33, 11B, 15, 64, 14, HLA-DR. Small GPI deficient populations. So erythroid, when they are having decreased CD71, B cell precursors, they are going to have decreased hematogones. So that's, I wanted to come to this, is an important one to see. So they are showing over here the normal maturation pattern and the abnormal maturation pattern. So basically the asynchronous pattern of antigen associated with maturity and in the MDS that they are showing. So basically they are showing the abnormal and normal. So normal over here, that there is this normal expression of the variability, but the abnormal in which there is CD34 as well as CD15, that is a blob that is sitting over here that we were talking, that it doesn't make any sense. So again, this normal has variable expression of 34, has variable expression of 33, but the abnormal will be a blob sitting with bright 34, bright 33, and so forth. So that's, and then the acquisition of 56, that's what they were saying, that acquisition of, so normally they will lack 56 in the progenitors, but when there is acquisition of 56, that's kind of abnormal. And then they are going antigen abnormality seen in maturing myeloid forms. Let's read this. So the upper plot is abnormal and the lower plot is a normal one. And you can see that 13 versus 16 is normal over here. However, you can see over here, this is kind of, this has to be like this. However, this is like decrease in 13 expression over here, if you may. So this is a population that has sorry, increase in the 13 expression over here. So that's something that's aberrant, see over here. Similarly, the 14 expression, the normal myeloids, as we know, the monocytes will have more of 14. These are the normal myeloids, which will have dim 14, and when they are maturing, they will acquire 16. However, when they start having higher 14, that's kind of abnormal. And over here, they are showing that this population over here, so this CD64 has to go down here, and this population is not going down there. There is this normal population, but this population is abnormal. So that's what they have been showing, normal versus abnormal things here. And this again is, we have seen this before. So this is kind of a left shifted population. So there is less of the 16 positive, these kind of mature cells. There are more of these immature cells. And so again, the 16 is, the 13 is more, and the 16 population is kind of gone. This is a regenerating marrow. So single antigenic abnormality should not be taken as evidence of myeloproliferative neoplasm. In contrast to the resting marrow, the lower panel, the resting marrow is A, normal. The lower panel is B, is taken from the patient with marrow regeneration and shows expression of low variable levels of 56. So that's what they were saying, that when there is acquisition in the myeloid monocyte of over here blast as well, of CD56. So that is kind of more suggestive of a regenerative marrow. So this is not like, this is just a small chapter that, we can skip that. So that I wanted to go through this for the completion sake too, and they have some important points in the Brent Wood. So either we can stop here because tomorrow we are going to have 1 hour session too in the morning, and then start with the cases tomorrow. We finished like 1 hour 8 minutes right now. Or if you want to continue, we can continue and see the cases, have more fun.
I'm okay with continuing.
Who said that?
Shweta.
Okay. Rajeshwari, do you want to show the cases then? Do you want to ask the cool questions?
Okay. Have you guys seen the cases? I placed 4 cases in the drive yesterday.
Sorry, I didn't do that yesterday. Sorry, I completely skipped that you have put in.
So I
So
would
I'm
say first see those cases. I mean, it will be best if you would first see those cases.
okay. Then we
Rajeshwari,
can do tomorrow too. I mean, if
Yeah,
it's
because
if
like
that
Rajeshwari.
we
case.
would, when you look at it by yourself, if in case you
Sure,
might
yeah,
come
I
up with
get.
more questions when you actually try to analyze them. So we
Exactly.
prefer that, like you see the cases beforehand.
Yeah, and then she puts the cases 1 day before or 2 days before. She's very good at that. So she already placed them, I think, in the day 2
I
or day
actually
3.
put, I didn't put it in this one. I think
No, this is the,
this is the one you
yeah.
merged it. Okay.
Yeah. So in the day 3 material, you'll have the cases B cell. So
Okay.
go over these B cell cases and think of your differential, think of what you want to ask and stuff like that. And once you are ready with those cases, we'll start discussing the cases. And this
Sure,
is for
sure, definitely.
like it doesn't take a lot of time to see those cases. This is very easy, and once like for Shweta, I mean, it will be very easy for you too. These are like all the regular run of the mill B cell cases. So
Yeah, we are starting light.
yeah. Okay.
All
Yeah,
right
sure.
then.
Okay. There was a question about compensation. I wanted to show this general gating. So
Okay, so in the meantime, Halima asked, you were saying that in these cases are there 2 tubes. So some of these cases, yes, I think most cases have 2 tubes, except maybe 1. But if, ignore that, then just try to analyze whatever you see. You will see different color population based on the tubes. That is correct. But you each tube will have either CD19 or 20 for you to identify the B cell population. I think in one tube it will be blue, the B cells. The other tube it will be brown for some of the cases, and in the other one the other one is one tube mostly. So you will see, you will understand when you see. I don't want to give it away right now, but you will be able to figure out. But keep in mind there can be 2 tubes.
yeah. Okay. So this was a question I think in the group Shweta has asked about compensation. I couldn't find any better example than this, but this was in our SOPs, and so basically what they are showing is when you do use the compensation libraries, you use the specific libraries for the specific panels, right? So in Woodlist they have the Scan 456 and T cell compensation and the other compensation libraries that they use for the particular panels. Usually what should happen is these compensations should be ideally be standardized to those panels and should not deviate, but that's not the scenario that always happens. And also when you have some some new panels that have been made by your lab itself, and they don't come with the compensation library. You have to make sure that you kind of properly compensate it. So when the population is not compensated, we would see this kind of triangular appearance, and also you can see over here this triangular appearance. And I think Rajeshwari in the morning mentioned about very nicely about this triangular appearance. Why does it appear? Can you repeat that, Rajeshwari? Are you here?
Oh, sorry, I was muted. So that is, we say more like it is like a diagonal shape, or some people describe it as rocket shaped. So it means that it is in between the two antigens, like in the midline, and it is not committing itself to either of the two antigens in that plot. And you will try to, if you see all the other plots also, you will see that population almost in the middle, and it will not be positive for anything, and you will see the population in all the plots in the same shape. That is a big clue that it is it could be a debris, or if the and then you will try to fix the compensation to see if it is a real population, or you can confirm it is if it is a debris. The flow techs usually do that when they see some such things, to make sure that it is real, or if they see that it's just debris, they would not gate it and put it in a box, or they will just leave it, clean it up.
Right. Usually all of this is done by the flow techs, as you are right. And sometimes you'll come across those cases where you have these kind of triangular populations, and you have to play with the compensation here and there, keep on changing it. And then finally you kind of get a population that you are satisfied with. So yeah, this is the only example I found about compensation. I mean, I don't know if we would be able to find more better clarity for this one.
I'll try
Okay.
to get some examples that more commonly you will see the graphs like kind of bending out in one angle. I'll try to see if I get more. I'm on service next week, so that I could get lucky, and I'll show you. The thing is, like, we don't save those cases, and it's not possible to search, because we just don't put it in the report or anything. So there is just no way of searching those cases. So I have to actually keep an eye out for it.
Right. Yeah. I mean, see if we are having like 15-20 days more remaining for the flow. If in these 15-20 days, if you come across these cases, you can just collect them, and in the end, maybe you can just show all
Sure,
the.
yeah, that's what I will do. Like, I might get something, and then I'll show you. Yeah.
Okay. All right, guys. I have
Bye-bye.
7 days that I have to finish.
Bye-bye. Bye-bye.
Now.
Thank you. Bye.
Bye-bye. Thank you.
All
Thank
right.
you, Akanksha.
Thank you.
Long
Bye,
day.
everyone.
Yeah.
Bye-bye.
Bye. Thank you.